Very good evening to one and all. I'm Dr. Chaitra, consultant pathologist at SigTuple. It's my proud privilege to welcome you all to the fourth SigTuple webinar in the series of digital pathology. So today's topic is digital pathology in the current era. So today we have our renowned expert and a well-known name in histopathology and oncopathology, Dr. Veena Ma'am, head of histopathology and digital pathology at HCG Cancer Hospital as our esteemed guest speaker. So she is the one who has established a network of digital pathology in HCG hospitals. So today's agenda for the webinar is first, we'll have a brief introduction to SigTuple's AI 100 by myself, which is followed by an amazing and an enlightening talk of digital pathology in laboratory practice by our expert Veena Ma'am, followed by a few case discussions. So, SigTuple is a medtech company which develops artificial intelligence powered digital microscopy solutions, that is our AI 100, which is a fully automated digital cell morphology analyzer. So, in SigTuple, we leverage the power of robotics, clinical data, and artificial intelligence to create a smart diagnostic solutions in the field of pathology. So with this, we are democratizing microscopy by enabling an AI-assisted remote review, which is unhindered by geographical boundaries. So AI 100 is a smart robotic microscope which converts the peripheral blood smear and the urine microscopy into the digital images. So AI 100 works with both manual as well as automated smears, and it is stain agnostic. So it works with all Romanowski stains like Leishman stain, MGG, and Bright stain. So I'll just give you an overview of how an AI 100 works. So as I told, it's a smart robotic microscope. So once you get a sample, you prepare a smear, stain the smear, and you load it into AI 100. The optical system inside will scan the smear, and the camera at the top captures the images, and these images are transferred to the cloud, where the artificial intelligence-based algorithms analyzes, computes, and provides the results with the visual evidence, which can be viewed by the pathologist on any internet-enabled device. So all you need is an internet-enabled device. So it could be your desktop, your laptop, your iPad, or even the mobile phones. So AI 100 is a one device with multiple solutions. So right now we have two solutions, that is Shonit for peripheral blood smear microscopy and Shrava for urine microscopy. Both Shonit and Shrava are CE certified. And we are extremely happy and proud to say that AI 100 with Shonit has US FDA 510K certified now. So in the pipeline, we have a universal scanner for histopathology and bone marrow and body fluids coming up. So AI 100 has three important features. It is more accurate with high sensitivity and specificity of the result, and it's affordable. And with a cloud-based remote review, it's more accessible. So we have our own software platform called Mandara. It looks like this. It's a very user-friendly platform. So you can see here we have WBCs, RBCs, and platelet categories. So in WBCs, we have a 7-part differential, including IGs, BLAST, and NRBC. And each category has a reference images, so where the beginners can have a look at it and compare. So in RBC, AI classifies the RBCs according to the size and shape and grades according to the ICSH guidelines. So in the platelet category, it gives us a platelet count, just like our manual microscopy. So it counts the platelets in 10 field of visions, gives you an average count, which could be multiplied by your multiplication factor. It can be 15,000 or 20,000, whichever you use in your routine practice. With the count, it also highlights the presence of platelet clumps and the giant platelets. So we also have an additional feature called microscopic view. Which simulates a manual microscopy. So as a pathologist, we will not miss our pathologist with this feature. So with this microscopic view and all the visual evidence, so we are in a transition from the manual microscopic era to the world of digital microscopy. So this is our team. So with this, I would like to conclude my talk. And it's my proud privilege to welcome Dr. Veena ma'am, Senior Consultant Pathologist and Head of Histopathology and Digital Pathology at TriStar Sciences, a unit of HCG. She's subspecialized in urogenital pathology, bone and soft tissue tumors, and female reproductive system pathology. So she is one of the pathologists with keen interest in research and academics. So she has a certification in artificial intelligence and machine learning from Texas University and has completed an advanced certification program in molecular oncology from SKCC at Australia. So as I said, she's one of the pioneers in establishing a network of digital pathology in HCG Hospital. She has delivered a number of guest lectures in several national and international conferences. She is the professor and guide for DNB pathology and fellowship students in oncopathology. Even I was one of her students. She is also a PhD guide for pathology and affiliated to RGUHS. She has several publications in her name in national and international journals. Over to you, ma'am.
Thank you, Dr. Chaitra, for the wonderful introduction and also your wonderful presentation. I would like to thank SigTuple for inviting me to share my experience with digital pathology, and I hope at least some of the audiences who are here are stimulated and are motivated to adopt to this technology. So I'll just share my screen. My screen visible?
Yes, ma'am.
So what I would like to cover in this today's session is I'll just give you a brief outlook of what digital pathology is and how it all started. And what are the limitations with the microscopy? So what is going to happen? What is happening if we continue to do with our manual microscopy? Whether digital pathology is the future or the present, because most of us seem to think that yes, digital pathology is the future, but let's see whether it's really the future or the present. And then how we can apply digital pathology in the practice of histopathology and hematopathology. I'll be sharing our experience of in my laboratory. And then definitely, if you are in a corporate setup or if at all, if you want to adopt any new technology, the cost will be one of the factors. So, some people say that, digital pathology cost, so let's see how digital pathology can be made cost effective. And also finally, what are the benefits of digital pathology to a pathologist, to the patient, to the clinician, and also the administration. So this is what I would be covering in my topic today. So I'm actually a pathologist at HCG, and I'm sure most of you are aware of it. This is a large chain of single specialty oncology hospital. We have about 24 centers across across India. And we cater to more than 1.2 lakh new cancer patients every year. And we have a team of 220 plus oncologists in our network, and about 80 of them are in Bangalore. And let me tell you that our clinicians are one of our strongest support for adoption to digital pathology. So we also have academic programs running. So we have DNB in pathology, and we also have fellowship programs. And in addition, we are also active in translational and clinical research with digital PET, FAPI therapy, and we also have the next generation sequencing. So, and digital pathology was one of the additions to all these latest technologies that we have had. And Bangalore is the reference lab where we have most of the almost all of these latest technologies. And at Bangalore, we are as a as HCG or TriStar, which is a laboratory part of HCG, we receive almost around 45 to 50,000 histopathology specimens a year. And we are a team of 10 subspecialist pathologists in our network. And as I said, Bangalore is the referral lab, and the digitization actually started in Bangalore way back in 2018. So it's almost 5 years since we have been using digital pathology. And we have also adopted to digital hematopathology almost 2.5 years ago now. So this is my team of histopathology in Bangalore. So we are 4 pathologists who practice subspecialty reporting. Then we have fellows and residents, and we offer all these services. And in Bangalore alone, we have almost like 25,000 to 28,000 histopathology samples a year. And we are 4 pathologists who are managing this number of samples. And we are accredited with CAP and NABL, and even our digital pathology with the AI/ML algorithm for breast biomarker is in the scope of CAP and NABL. And this is my team of hematopathology. We are 2 hematopathologists and fellows and residents. And this is our sample numbers in hematopathology. And hematopathology in Bangalore is quite a busy department. And particularly as we cater to oncology patients, it's much more challenging as such. Just to give you a brief of what, how digital pathology evolved, Zachariah Janssen was the first person who basically was, a glass maker who accidentally happened to detect or invent a microscope or design a microscope way back in 1585. And then it was Robert Hooke who actually sort of designed a microscope in 1665. And then again, Anton von Leeuwenhoek, again, who gave a little more, ergonomically designed microscope to us, again, in 16th century. And almost in 16th century, microscope has become a sort of, very close to the heart of a pathologist. And we are so closely attached to that we don't want to let it go. So that has been our mindset from 16th century. So we have been trained on the microscopes. We continue to use a microscope and we don't want to let it go. And let me tell you, if you're adopting to digital pathology, you are not going to let your microscope out of it. Right. So it is not it's definitely not a substitute to your microscope. It is going to be a supplement to your microscope. So you should not feel that, I am going to misdiagnose. No, that's absolutely not the case. And then to give you a history of digital pathology per se, we all are very familiar with taking snapshots, taking micro photographs, etc. So that actually started somewhere in 1950s, 1960s, where people used to take photographs of the slides and used to exchange. So and then actually the first telepathology was introduced way back in 1964, where in US, the Armed Forces hospital used it for the first time to report a frozen section in Mississippi. So that was the first time when the digital era started. So it's almost like 1965, so it's almost like, some 60 years, way back 60, 70 years, that digital pathology has started evolving. And we are talking about digital pathology today. So why is that? We'll just see in the subsequent sections. And then it was in the year 1995-96 when the first whole slide image scanner was introduced by James Buckman, and he was the one who actually introduced the first whole slide scanner. So when I say a whole slide scanner, it is a scanner which scans the entire slide. It's not the snapshots or not the images or patches of the slide. So he was the one who introduced in 1985, and it's almost like 28, 30 years, and we still continue to discuss about digital pathology. So if you look at the radiologists, the digitization in radiology started later, somewhere in 2005, and they adopted so well to digital radiology. And we are still talking about digital pathology even today, again with two minds, whether to adopt or to continue with our microscope, because microscope is so close to our heart. Just to give you a reference to this article, a wonderful article, which actually looked at the limitations. So why pathologists are reluctant to look at digitization, why they don't want to adopt to digital pathology, because it's almost 60, 70 years and we're still talking about digital pathology, right? So this article beautifully, gives the reasons. This is actually a survey. And they say that there are professional issues with the pathologist quoted, and there are personal issues as well. So professional issues were like, lack of training, and there were no guidelines. And then there is lack of trained technicians, lack of infrastructure. And then pathologists actually work in isolation. So we feel very comfortable working alone. We don't want to work with our fraternity. We don't want to exchange anything with our fraternity. And reluctance to accept new technology. So this is one of the important things. Radiologists accepted digitization, but we pathologists are still talking about it. So we are reluctant to accept any new technology, and we still want to continue with our microscopy. And there was no compulsion. Nobody said that you should use digitization. So nobody said that. So we continued to do what we were comfortable. There were personal issues which are quoted in this article. And I would like to just bring your attention to this one: pathology, a sleepy subject. So once you finish your post-graduation, we just want to get into medical colleges and then, have a happy life. So that's what everybody wants to do. That is as per this survey. It's not what I'm saying, but this is as per the survey. So there is lack of motivation, and there is a lot of hierarchy. The senior pathologists don't want to change, and at the same time, they don't want the juniors also to adopt to new technologies. And these are some of the reasons that are quoted in this article. So it's a time to ponder about these reasons, right? So now let's look at the current era. So what is going to happen if we continue with our microscope reporting, right? So we are in the era of precision oncology, where the treatment protocols, are tailor-made for each patient. So what happens if we continue to report on a manual microscope? So you have now tumor boards, we have now, multidisciplinary team meetings, we have quality control programs, quality assurance programs, we are adopting to accreditations, and then we are participating in proficiency testing programs. So we end up spending almost 10 to 20% of our time in all these activities. So if you still continue to do with your manual microscopy may not support all these activities. And so you have to spend a lot of time in preparing for these activities. And then we have a lot of subjectivity. There are several articles that are available which say that the subjectivity between the pathologists can vary from 5 to almost 50% in some cases. So there is a lot of subjectivity that we have seen in our routine practice, and the cases are becoming complicated. So we don't have many expert pathologists, or the existing pathologists are overloaded with general cases. So who's supposed to do what, who's doing what is again a question, and that continues if we continue to do with our microscopy. And we are not integrating our pathology reporting with other areas. Like, for example, we don't integrate a pathology with the clinical diagnosis, with the radiology diagnosis, the genomics data. So we work in isolation. So if we continue to use the microscope, we again still continue to be away from all these latest technologies, which ultimately are going to have an impact on the patient's management. So this is one. These are some of the limitations if you continue to do with the manual microscopy. But I don't say that if we continue to do with the manual microscopy, we are compromising on the patient's report. But in the current era, it's always better to adopt to the latest technologies. And we know that we do have certain challenges in pathology which needs to be addressed. Right. So if you look at this publication from WHO that was published in, I think, 2010, which clearly says that by the year 2025, the oncology cases will actually increase by 70%. So we are going to have an increase in the cancer cases by 70%. And it's not just an increase in the number of cases, but the cases also are becoming very complicated. And this complexity of the cases and the lack of integration with the other modalities actually is resulting in a delay in the reports in almost 41% of cases. And also the all the expert pathologists are located in the metros, and it is difficult to approach them from remote locations. So this is one of the limitations or a challenge that we have today. And as I said, we are in the era of precision oncology or precision medicine, where a pathology diagnosis has to be substantiated by evidences. And that evidence actually comes from immunohistochemistry, our genomics, molecular data, etc. So we have other diagnostic modalities which are coming up and which are actually supporting the pathology. So we have to adopt to these technologies, and then this is all in the benefit of the patient. And then what used to be the reports, like a descriptive report, one-liner report, actually is not going to be held valid again, because as I said, we need to have evidence-based diagnosis for the practice of precision medicine. And all this is possible only through the digitization of our pathology services. So when we looked at digitization of our histopathology services, we also had similar challenges. So we had an increasing workload of cases year on year. Cases were becoming very complicated, and it was difficult to recruit experienced pathologists for us who were trained in oncopathology reporting. And as I said, we have 24 centers, and Bangalore is the reference laboratory. Providing the same quality of reports as in Bangalore in remote locations was a challenge for us. And with manual microscopy, staging of the tumors was becoming a challenge. So if you take head and neck tumors, a depth of invasion of 5 mm, 6 mm, or 4 mm, 5 mm actually makes a lot of difference in the management of the patient. So when we usually measure, if we are measuring the depth of invasion on the microscopy, we usually try to mark it on the glass slide using the markers. So the marker tip itself can be an 1 mm thickness, in which case the stage can significantly vary. So this actually affects the patient management, and this was one of the reasons where we actually wanted to have an accurate staging of the tumors. And then maintaining the turnaround time of the reports with increasing number of cases was again a challenge. And whenever we had to go back to the previous slides for review, we had to dig out these slides from the archival, and that used to take a lot of time for us. And every day we have multidisciplinary team meetings. So again, preparing for these MDTs used to take a lot of time for us. And getting samples, slides and blocks from the remote locations was becoming a challenge, adding to the cost and the risk of loss of precious material and the time spent in the logistics. And we had, as I said, we have 10 pathologists who are experts in histopathology reporting. So some of these pathologists' efficiencies were actually not utilized appropriately. So they were actually doing less number of cases, or they were not reporting cases in which they were experts. So this was another area which we had to address. And as I said, we are an academic institute, so using the digital slides for education and biomarker research was actually another thing that actually motivated us or pushed us to the adoption to digital pathology. So as I said, the drivers for digitization for us was basically the practice of precision oncology, where we had to make the right diagnosis the first time so that the patient gets the right treatment the first time in the management of cancer. And utilization of pathology services, and then remote locations, providing the reports on time, providing the same accuracy of reports, within a short turnaround time, and then reducing the glass logistics, and then research and academics. And another important area for us was to have the collaboration, or prepare or have a big data with collaboration with the electronic medical records, the risk facts, the radiology, the genomics, the biobank, etc. So for every patient, we wanted to have a complete data set available. So with digitization, we were able to do this complete case details with the generation of the big data. So these were some of the drivers for digitization. So this is what I said, big data. So we have electronic medical records, the PACS, radiology, and then education, MDT meetings, and then research and collaboration, and the molecular and the genomics data. So everything on one desk or one screen. So this is what we were actually looking at. So let me just take you through the implementation of digital hematopathology in our center. So actually we have the main reference lab in Bangalore, where we have what Chaitra has briefed about, the AI 100 equipment. And we have 3 more AI 100 equipments in our remote locations, 3 of our remote locations, that is in Ongole, Vizag, and Ranchi. So we actually looked at the distributed processing, in the sense placing these equipments in these remote locations, and a central reporting. That means reporting happening either from Bangalore or any other pathologist in our network, agnostic to the location. So this was the idea behind adoption to digital hematopathology, because in a center like Ongole, we were not able to find good pathologists. And this was actually affecting the patient's management. So that's the reason we thought that, reporting can happen from Bangalore or from any other location where we have a competent pathologist, and processing can happen in the local location. So we looked at the digital hematopathology thing. So this is the same reasons I said, no pathologists available in remote locations, and there was no control over remote locations, and the stability of the samples was an issue if they had to be shifted from these locations. Turnaround time was longer, and also whenever the glass slides were sent, there was always the fear of the slides being broken or slides being lost, etc. And hemato-oncology is a very important and a critical area. So particularly if you have APMLs, which where the diagnosis has to be given immediately. So patient safety was another concern for us. So this is the AI 100 equipment, which Dr. Chaitra has already spoken about. So this is the equipment that we have adopted. Four such equipments are already placed in our locations, in 4 of our locations. So this I will not go in depth. So as she has already explained, we can actually have a look at the morphology. This has an inbuilt AI which works on the CNN model, that is the convolution neural network model, where it actually subclassifies the WBC. So this way, the clinicians were very happy because they were able to get a accurate counting of the blast, as well as the presence or absence of the blast, and also an approximation of the possible diagnosis. So they were happy with this feature. And in the RBCs also, it is able to predict the type of the red cells, and then the morphology, and also the different poikilocytosis, anisocytosis, and the possible anemia. So this was also another feature that we were able to use it for our clinical practice. And as I said, the Bangalore is the central hub, and we have AI 100 in our 3 more locations. So all images from these actually get uploaded onto the cloud, and the AI model will work on these images and gives a pre-classified report. So our pathologists in Bangalore will actually go through these images, but also we have 2 more pathologists in our network. One is in Vijayawada, and the other one is in Kolkata. So they also have a look at the images, and we have designed it in such a way that there is an email alert that goes to the pathologist that this particular case is ready for viewing. So they usually see that and then they report. So with this adoption to digital hematopathology, our connectivity with our centers has improved actually, and then we are able to scale up better with the available resources or with the low resources. Our glass logistics cost has actually come down drastically. Sorry, slides are moving faster. Logistics cost has come down. The turnaround time is far better because the clinicians are able to get a faster report and a more accurate report from experts. Our efficiency of pathologists in other locations has also improved. Their productivity has improved. And with these images being available in the cloud, we are able to make use of these images for the further research activities. So just to take you through a validation study that we did. So this was a study in Bangalore we did with 436 samples, and it has shown a very good concordance rates for WBCs, RBCs, and the platelets as well. This is the validation study at OnGoal. When I say validation, we are comparing the machine reading with that of a gold, what we say as gold, the ground truth, that is the pathologist reading. So it has shown a very good concordance. This is the location at OnGoal, where it has shown almost like WBC morphology 100%, peripheral smear impression of almost 100%. And this is at Ranchi. Again, it has shown almost 100% concordance with the expert pathologists in Bangalore and the pathologists in Kolkata. So with adoption to digital hematopathology, these are the benefits that we have seen. Reports from expert pathologists within a short turnaround time is available to the clinicians. This is saving on the recruitment of pathologists. So this saves on the logistics costs, and the clinician satisfaction is far better. So this we actually did a short survey to understand the clinicians after the implementation of the AIML model, the digital hematopathology, and they were very happy with the quality of the reports. the critical alert information coming from the equipment. Then they were able to access the expert pathologists across our network, and it correlated well with their clinical diagnosis, and also they were happy with the turnaround time when compared to the previous one. So this actually shows that digital pathology actually is one of the very good tools if you consider the patient safety and the clinician satisfaction. And if you want to please your management, it is actually an indirect cost saving, which saves on the recruitment of pathologists, because this is agnostic to the location of the pathologist, and your logistics cost is actually taken care. So we actually looked at the cost benefit analysis for digital hematopathology, and this is what we have found actually. So based on the number of pathologists required without a scanner and number of pathologists who are available with the available scanners, and then with an increasing number of cases, and then salaries without AI, salaries with AI, and what is the saving. And definitely there is a saving that you can see in this slide. Now coming to the digital pathology implementation in surgical pathology. So this is a slightly different concept. So as I said, Bangalore is a reference lab, and the processing, what we planned is to get the samples to Bangalore, process it in Bangalore, and have a distributed reporting. So as I said, we have 10 pathologists in our 10 histopathologists in our network. So the concept is to distribute these cases to our pathologists in the network, so that the reporting happens in the peripheral locations. The processing happens in the central location, and the reporting happens in the peripheral location. So this was the concept here. So the same, we had the same limitations as I briefed earlier, like increasing number of cases, and then improving the efficiencies of the pathologists, bringing accuracy of reports, uniformity of reports, and then practice of precision oncology. So all these were the drivers for digitization. So we started with the implementation in a phase-wise manner, starting from the selection of a scanner, validation of a scanner, then bringing in workflow changes to adopt to this technology, then doing a prospective validation, integrating this with our LIS system, and then validation of our machine learning algorithm, then what are the other value added services that this technology could provide us, and then validating them, and doing a cost benefit analysis, and building up the network pathology network in HCG. So these are the criteria that we used for the selection of the scanner, that is capacity, scanning time, how much time it takes. To way back in 1995, when James Buchanan actually designed the first whole slide image scanner, it took 24 hours to scan one slide. So we didn't want something like that. So we looked at a scanner which is much more faster, gives a very good quality of report with quality of images. So that was one of the important criteria for us, because we didn't want anything to be missed out. And then size of the image was again one of the issues, because these surgical pathology images are quite big, almost like 2 to 3 GB. So size of the image and other value-added services, whether it's able to support that. And then whether it's able to support in the networking of other centers, and then integration or interfacing with our LIS, and whether the images can be used for education and research. So these were the criteria that we used for selection of a scanner. And this is what we have currently. So we have a data center in-house in Bangalore. We have actually 2 scanners, and it is supported remotely by the service center. And this is integrated with our HL7 LIS model as well. So where we are today is that we receive samples. Sorry. So samples come from different locations to Bangalore. They get processed here. Slides are prepared, then they are scanned, and then they go to the pathologists in other locations for reporting. So we have a pathologist in Nagpur, we have a pathologist in Ranchi, we have a pathologist in Hubli, and we have a pathologist in Vijayawada, who are a part of our network pathology, apart from the 4 pathologists that we have in Bangalore. So we did a validation. This is a retrospective validation where, after a washout period of about almost 3 to 4 months, we pulled out slides, and then we scanned it to see, and then asked the pathologist to report and compared that with the light microscopy. and it showed a very good concordance of 97.3% in the retrospective validation. So when we did a retrospective validation, it actually gave us ideas, also leads where to work on. So where to improve, for getting a very good quality of image. So we had to work on that, train our technicians to make good quality slides, good quality, so that good quality images are produced. And with all these changes, when we did a prospective validation, that is day-to-day reporting, comparing that with a microscopy, our concordance rates improved to 99.3%. So these are the other value-added services that digital pathology has brought in our hospital. So if you look at the top image, this was the quality of slides that we had. That is, the DPX sticking all over, cover slip outside the slides, and then handwritten labels, and then tissue spread all over, very uneven tissues. So all these are addressed with an improvement in the workflow. So what you can see is, evenly placed tissues, very evenly placed tissues, uniform sections, and then barcoded glass slides, and no excess DPX, no sticky labels, no cover slip out of the labels, out of the slides, etc. So our slide quality has improved, and this has actually helped in improved image quality as well. Now we'll do frozen sections as well. So we are able to take image of the frozen specimen, attach it to our, the whole slide image in the scanner, and then we are able to communicate directly with the surgeons in the operation theater. So we are able to mark areas in this and show it to the surgeons in the operation theater. So you can see the screen here. He is the operating surgeon, so he is able to see what we are referring to, which margin we are referring to, and then he is also able to see the slides and then mark the areas. So conversation has become very easy. And then now in the multidisciplinary team meetings and tumor boards, we actually don't spend any time because we can access it from any location. So we usually directly go there and then open the case, including the gross specimen, the test request form, and the whole slide images, and are able to communicate better to the clinicians in the meeting. And this has been actually interfaced with our laboratory information system. You can see here, you can see the gross specimen, the test request form, and the images as well on the screen. And we are able to actually, as I can see, show in the next slide, you have a slide here, and we have our LIS. So it's very easy to transfer or dictate the reports directly into our LIS. So as you're seeing a case, you can actually go on dictating or typing, so that by the end of the case, you are ready with your report. So your report is also ready. And we also have the LIS integration, in the sense, if we open our LIS, through our LIS, we can actually access the images through the LIS. So so that only this particular case image opens, and we can see this image, and then simultaneously complete the reporting as well. So that is called contextual launch, and we are able to incorporate snapshots also in our reports. And then after the end of the prospective and the retrospective validation, and when the pathologists were comfortable, we actually did a survey. And pathologists are now, all our pathologists are quite comfortable with reporting on digital pathology, because what we see is, though our workload compared to 2020 and now 2022, workload has gone up by almost 37%. But we four pathologists are still able to manage the existing workload, because the reporting is much more simpler and much more easier and faster with the digital images. And this is the algorithm, the machine learning algorithm for the interpretation of the breast biomarker. This is a part of computational pathology. So we did a validation of this, and this has shown a very good correlation of almost 97 to 98%. And particularly the HER2 cases, equivocal cases, 98.9% of them actually had shown a concordance with the FISH reports as well. So we also monitor the digital pathology, services. So we have certain quality indicators which we monitor on a day-to-day when we report, and also month-on-month we keep monitoring all these. So we did, during the COVID time, we pathologists actually reported from our homes, and we actually published our experience of remote reporting. That was published in the Journal of Pathology Informatics. And this is another publication again during the COVID time, where we were able to pick up fungus, the mucor and the aspergillus on the digital images. And this is also published in the Journal of Pathology Informatics. So as I said, we are academic institute. So we use these digital images. We are building a digital slide archive, and we are using these digital images for training young pathologists. So all our, the students, whether they are DNV students or fellows, they all are comfortable with the whole slide images. And we have about 8 workstations in our laboratory, and everybody uses, and they're quite very comfortable with the whole slide images. And we have had webinars on digital pathology, computational pathology, and we are enabling a change management within our HCG network. And we have been a part of a couple of research projects with the machine learning algorithms. So as you can see here, and we have also worked on spatial transcriptomics and spatial proteomics projects with our digital slide images. So these are a couple of academic programs that we have conducted in digital pathology. And this is the caseload that I was telling you. The workload has gone up, but we are able to manage with the existing workload. So there is no additional pathologists since 2018. And there is an increase in the case volumes per pathologist as well compared to 2018. And this is the cost benefit analysis that we did, looked at the increasing workload with the additional pathologists, what would have been the cost, with the existing pathologists, what is the cost, then the usual, the logistics cost and other things, everything was taken into consideration. And it definitely shows that there is a cost benefit with adoption to digital pathology. There are other indirect benefits that we have seen with digital pathology. Turnaround time is far better, because as I said, the reporting is much more easier and much more faster. These are a couple of examples. So mandibulectomy, head and neck case, which used to take almost 30 minutes on a microscopy, we are able to do it in 19 to 20 minutes. And breast conservative surgeries, again, BCS 21 minutes earlier, 15 minutes now. Radical prostatectomy is almost an hour we used to take for reporting, and now it is almost 40 to 45 minutes. Our staging is much more accurate because we have many annotation tools in the whole slide images, or the image management system, which we use more comfortably. So we don't have to spend much time on the measurements, and staging is much more accurate. Even isolated tumor cells, we are able to pick up very accurately in the whole slide images. It has significantly improved our pathology workflow. And pathologists and clinician dialogues are much easier now, and that is one of the important advantages that we have found. And we are generating big data, as we have integrated that with the EMR, PACS, and the genomics data. So it has improved the efficiency of other pathologists through the network pathology. So this is where we are today. We are a totally digital laboratory. So we have been awarded as the first 100% digital pathology in the country way back in 2019. And we have completely adopted to the digital whole slide image reporting. And reporting in hematopathology with peripheral processing and central distributed reporting has made an impact on the patient's safety and the clinician's comfort. So they're very happy with that services. And remote reporting is, what happens now. Sometimes when we are taking leave, also sitting at home, we do report. And it has streamlined the workflow. It's ergonomically designed. We are able to take more cases. Turnaround time has improved the accuracy of staging, and also we are part of education and research. And with the subject computational pathology playing a significant role, our subjectivity in pathology is reducing. So these are some of the advantages that digital pathology brings in. It's for every field, like whether it's a digital hematopathology or a digital surgical pathology. Definitely there are advantages for the pathologists, for the laboratory as such, for the patients, for the clinicians, and the administrators. So particularly for administrators, the pathologist efficiency is improved, so there is no need to recruit more pathologists. And the patient satisfaction is better because they are getting much more accurate reports within a short turnaround time. Clinicians are happy because they get more accurate staging. They are able to get expert opinions or expert pathologist opinions, and intraoperative consultation is much more easier. That is better. And for patients, again, it's much more beneficial because they get much more accurate reports, and they get reports from the expert pathologists within a faster turnaround time. And in the laboratory, the workflow has definitely improved with much more traceability of the samples and archival of the slides, because we don't have to go back and search the slides in the archival. We can easily pull out these images from the image management system if we have to correlate the previous biopsies. And for the pathologists, it's much more easier because it's ergonomically designed. It is much more, image quality is far better. It is very time saving. We don't have to spend much time on preparation for any of these meetings. And reporting is much more accurate with many annotation tools. We are able to build network pathologists. If you want an opinion from an expert pathologist anywhere, you can actually share the link and ask them to give an opinion. You don't have to physically send the slides and the blocks to them. And yeah. So pathologist profile is improved in MDTs and collaborations, and this is definitely improving the pathologist training and their accuracy. So I would like to just wind up my talk with this quote by Dr. Anil Parwani, who says that the day is not far when digital pathology will just be called pathology. So it's for up to us, the pathologists, to start adopting to this technology right now. So I don't see digital pathology as the future. I think it is the present, and it is for us to look at this technology and start adapting to this technology, because this is definitely one of the biggest tools that we have in the current era. So thank you so much. If there are any questions, I'll be happy to answer.
Thank you, Dr. Veena, for a wonderful presentation. Can you hear me?
Yes, please go ahead.
I would like to know if you have made any publications regarding the validation of the SigTuple A100 instrument between pathologists and the manual reading of the microscope slides. Have you published it?
It is ready for publication. So actually, Dhaka, I would like to answer that question, because we had an agreement with them till they have that FDA. We were not supposed to do it. So our data is ready. We will be sending it for publication.
Okay. We just wanted to see the methodology that was being followed for that one, because we also, I am from the veterinary pathology side, and in fact, we are also doing the same thing with respect to the pet animals. The adoption of the same a SigTuple system for animals. Yeah.
Sure. I'll be able to share the paper once it is published.
Yes. I shall interact with Manohar Dayaka or Dr. Renu about this.
Yeah, this is Manohar, sir. We have recently gotten, just a week ago, we got FDA approval for the same. Basis the validation that we have done as HCG is one of the site of 4.
Yes, sir.
So we'll be publishing that as well across our veterans. Yeah.
Thank you. That will be helpful for our studies as well, as you know. Right.
So, Dr. Gopal, we are also in view of publishing the paper of the FDA paper. So we'll share it with you as well.
Another thing is, do you have a training program for the pathologists? They are all in remote areas. How do you get all of them to, do you have a training schedule for these pathologists at the centralized lab, or what is the way you interact?
It's all through the, all these Zoom meetings. It's all virtual trainings that is done for them. And then they're given these slides for interpretation, and then they are discussed again virtually with them.
Okay, so there is some kind of an evaluation process that is done before and after.
Yes. Yeah. Initially, like we will be having some sort of training for them. followed by, we give them the validation slides and then, compare that with a expert pathologist in Bangalore. And then, month on month, we give them, some selected cases, some 4-5 cases for them to interpret, and then we monitor it.
Okay.
And at any time, if they're not comfortable with reporting on any case, they can actually they usually approach our, other pathologists in the network.
Right. It's very, very interesting and very informative that how you could, link the pathologist data with the clinicians, which is very, very vital. And you have thrown light on a very important aspect of this. And, definitely you are a real torchbearer for digital pathology. Thanks.
Actually,
thank you very
our
much.
clinicians are one of our biggest supports, actually.
Yes, of course.
Yeah.
To make them understand the process itself is a very big task. And definitely, thank you very much.
Hi, ma'am. One of the participants has asked one more question to you, ma'am. That is, have occupational injuries of pathologists reduced due to automation of peripheral blood smears in your experience?
I don't have any first-hand data on this. Maybe I can come back to you on this.
Good evening, doctor. This is Suresh Vasu from Dubai.
Hello.
We are supposed to be, distributor here in Dubai. And I have one question about, how do you see the difference between our competitor in Philips?
You're talking about...
You must be using both machines, so A100 and other machine from Philips. I don't know other competitors here. Then how do you see the, A100 position?
Yeah, so Philips is also FDA approved, and the limitation with Philips as of today is that it can do only the histopathology part. So they don't have the technology for the hematopathology or the cytology. Cytology you can do to some extent, but not hematopathology, because we actually did a validation, but we were not too comfortable with the the images, because it needs to have a Z stacking for doing these hematology and bone marrow smears. So that technology is currently not available with the Philips existing scanners. Similarly with AI100, I mean, they are quite comfortable with the hematopathology, and we are working on the validation of the bone marrow and histopathology as well with them. So once we have some consolidated data, probably I'll be able to share that with you, and then maybe we can then compare both. So as of now, these two are in two different segments of the pathology. So, but the advantage with AI100 is that it is much more cost-wise, it is much more, economical compared to Philips. I would not say much more, significantly economical when compared to Philips. And it's a very small system, you don't need so much of trained manpower for this, etc. Whereas Philips is a huge system, and you need to have a lot of training for your people if you have to. So maybe once we once we are done with the validation, then probably I'll be able to share much more data with all of you.
Thank you, doctor. Thank you so much.
Thank you, ma'am. Thank you for that wonderful session, Meena. And I urge all the participants to either type their questions in the chat box or bring up their questions at the end of the session. Now I call upon Dr. Chaitra, who will be presenting some interesting cases from which were reported on AI100 at our partner labs. Over to you, Dr. Chaitra.
Thank you, Dr. Pavitra. Can you see my screen?
Yes, ma'am.
Yeah, we can see your screen.
Yeah. So now we'll discuss a few cases which was reported on AI100. So as we all saw, digital technology is transforming the healthcare industry, and it's revolutionizing the process of diagnosis, making quality healthcare more accessible. So reporting on AI100 would reduce the turnaround time, and it has helped a lot of patients to get treatment on time. So we'll see such few cases today. So coming to the case one, We had a 4-year-old child who presented to an emergency department in the late evening with the complaints of breathlessness, and on examination, patient had pallor. So the CBC revealed a hemoglobin of 6.8 grams, and WBC and platelets were normal. So the clinician was very anxious to know what kind of anemia it is, and is there any abnormality in the smear. So we scanned the smear on AI100. So this is the microscopic view which I was talking, which is very similar to our manual microscopy. So this showed microcytic hypochromic RBCs and the platelets were adequate. So an AI categorizes the RBCs according to the size and shape and are graded as well according to the ICSH guidelines. So in this case, we had grade 3 microcytes with the visual evidence. So, and in the poikilocytosis, we could see target cells and elliptocytes. There was no other abnormal cells. The differential count was within normal limits and the platelets were adequate on the smear. So with this, this was a case of severe microcytic hypochromic anemia, which was reported by a pathologist in the late evening within few minutes using the remote access and with the visual evidence, which is given by AI100. So the clinician could know the type of anemia and help them for the further investigations, and the arrangements for the blood transfusion was made on time. So ultimately, it helps the patients to get treatment on time. So coming to the second case, we had a case of 35-year-old patient with a clinical suspicion of thrombotic microangiopathy on a weekend. So clinician calls you and asks to look for a schistocyte on a weekend. So you need not travel from your house to the lab or the hospital. So instead, you can use AI100 and you can scan the smear on AI100 and see it. So in this case, AI picked up schistocytes and it showed the visual evidence and was graded as 3+. So in the routine practice, we don't sit and count each and every RBCs. So, but an AI does it. So in this case, you can see it's counted more than 2,500 cells. The percentage of schistocytes is more accurate compared to a manual microscopy. So the RBCs are graded according to the ICSH guidelines. So this is the ICSH guidelines. So the percentage is very important in cases of presence of schistocytes, especially in case scenarios like this, and even in cases of renal transplantation, clinicians will be behind you asking whether can you see schistocytes and what is the percentage. So in that cases, AI100 will give you the percentage with the visual evidence. So this case also had 4.6% of nucleated RBCs with the visual evidence. So, and had thrombocytopenia. So as I told, AI100 gives you a platelet count similar to a manual microscopy. So it counts the platelets in 10 field of views and gives you an average count with which what you can multiply with your multiplication factor, which could be 10,000 or 15,000 or 20,000, whichever you use in your regular practice. So with the presence of schistocytes, nucleated RBCs, and thrombocytopenia, it was a case of hemolytic anemia. So even on the weekend, the pathologist could report confidently the presence of schistocytes and the percentage of schistocytes with the help of AI100. So next, coming to the case 3, we had a 44-year-old male patient who presented with fever in the late evening. So the hematology analyzer showed a platelet count of 20,000 and the rest of the parameters were normal. So it was a case of dengue and clinician was suspecting dengue and was making arrangements for the platelet transfusions. So, and called upon the pathologist to see the smear. So we scanned the smear on AI100. So AI100 could pick up 130 platelet clumps and 58 gene platelets with the visual evidence. So the pathologist could call back the clinician and inform that this is a spurious thrombocytopenia case. So there are platelet clumps on the smear and the count is adequate. There is no need of a platelet transfusion. So coming to case 4, a 62-year-old female came to an emergency department on a Sunday with complaints of fever and fatigue and on examination, patient had pallor. The CBC findings, hemoglobin revealed 7 grams per deciliter. WBC count was slightly increased, or 20,000, and platelet count was 13,000. So the smear was scanned on AI100. So microscopic view showed increased WBCs, and there were a few large cells. So we also have an option of zooming in the cells to look for the morphology. So you can roll over the image to zoom it, or you can just click on this plus button to increase the magnification. So AI gave a differential count with 39% blasts, and this is the patch view wherein we can see the blasts with high NC ratio, fine chromatin, and conspicuous nucleoli, and the few blasts also showed our rods. So with this, all the morphological details are very clearly appreciated on our AI100. So, and you see all the blasts in one frame. Especially this will help when your blast counts is very low. You can see all the blast in one go, in one shot. And if you feel that this cell is not a blast, you could reclassify into this specific category, and your differential count will be changed at one go. So, and this patient had thrombocytopenia. So with 39% blasts and or rods, so the pathologist could confidently report that this as acute myeloid leukemia on AI100, and further recommend the panel of markers for flow cytometry. So using of AI100 obviates the need of the presence of the pathologist in the lab 24/7 near the microscope. So coming to case 5, we have a 40-year-old male patient who came to a primary healthcare center in a tribal area where pathologist was not available. So patient presented with fever and abdominal pain, and patient had splenomegaly. So the only test which was available there was a CBC. So hemoglobin was 7.5 gram per deciliter, WBC count was 45,000, and platelet count was 9 lakh. So this case was reported by a pathologist using remote access option of AI100. So pathologists sitting in Bangalore could see this report. So this case showed increase in WBC count, and there was increase in neutrophils. So coming to the differential count, there was shift to left. So here we could see beautiful myelocytes and metamyelocytes. So AI has already classified the IGs, subclassified your IGs, and we had monocytosis, and there was basophilia. So AI100 not only picks up neutrophils, lymphocytes, monocytes, and eosinophil, so it has a high sensitivity and specificity for identification of IGs, basophils, and blasts as well. So this case had thrombocytosis. So this case was reported by a pathologist sitting in Bangalore as chronic myeloid leukemia in chronic phase. So we also have an option of typing the peripheral smear impression and approving the report and sending it to the clinician, so the patient gets treatment on time, and further molecular investigations can be sent immediately. So coming to the case 6, we had a 68-year-old male patient with the complaints of weight loss and hepatosplenomegaly. The CBC findings revealed hemoglobin of 6.8 gram per deciliter, WBC of 54,000, and platelet count was normal. So in this, AI classified gave a differential count of lymphocytes was 94% with the visual evidence, and there was no blasting. So on the microscopic view, we could see increased number of WBCs, increased number of lymphocytes, and we could also well appreciate the smudge cells and the baskets or the basket cells. So this, in this case, platelets were normal. So it was a pretty straightforward case of CLL. So not only you can use when the pathologist is not there, AI100 can also be used in our routine practices because we have AI100 is more accurate with high sensitivity and specificity of the results. So coming to case 7, we have a 20-year-old male who presented with fever, with chills and rigors. So hemoglobin was 10.8 gram per deciliter and WBC was 8. 100,000 and platelets were reduced, it was 80,000. So we also have a value-added additional feature that AI-assisted malarial parasite detection. So in this picture, we can see beautiful vivax rings and the trophozoites. So AI 100 also gives you the species name and the ring forms, or whether the trophozoites are seen. So as a beginner, we tend to miss ring forms, but an AI will pick it up with a good sensitivity and specificity. So this was another case where 25-year-old female presented with a fever and headache and muscle aches. So CBC was done and hemoglobin was 11.8, WBC was 8,000 and platelets were reduced. It was 60,000. So in this case, even the clinician did not suspect malaria, but AI picked up malaria. So here you can see beautiful banana-shaped gametocytes of Plasmodium falciparum. So even when the count is low, the AI has picked up with. So not only the AI gives you the categorization of RBCs, WBCs, and platelets. So AI 100 can also be used for detection of malarial parasites with good sensitivity and specificity. So with all this, I would like to say that digital pathology solutions have the potential to address the diagnostics, the logistic, and the operational challenges in the laboratory. So it can decrease the turnaround time and thereby increase the productivity and efficiency of the pathologist. So with the remote access, you can verify and approve the reports. It obviates the need for the physical availability of the slides and microscope during reporting. And it enables the telepathology and creates a vista of opportunities for the educational and the research activities. So with this, I would like to say artificial intelligence and AI 100 is a perfect companion for a pathologist. So with this, I would like to end my talk. Thank you.
Thank you, Dr. Chaitra, for showcasing all those wonderful cases. I'm sure that AI 100 has helped the pathologist to a great extent in all these cases by displaying all the visual evidences of all the abnormalities in each of these cases. Now the floor is open for questions. I don't see any other questions in the chat box. If anybody wants to unmute themselves and ask their questions, they're welcome. If there are no more questions, I would like to urge all the participants that in whichever cadre or category you are practicing pathology, whether you're a resident or practicing your own private practice or in the lab or in any medical college or hospitals, if you get a chance to get a first-hand experience with digital pathology reporting, please try it out for yourselves and know the benefits. If there are no more questions, I would like to conclude this session by thanking Dr. Veena ma'am for gracing this occasion.
Pavitra, there is one question in the chat box.
Is it? Okay.
Yes.
Interesting case studies. Are there cases in which you have opportunity to test the samples after treatment? Same sample after treatment. This question is by Gopal Krishnan Nair. Be more specific in which diagnosis you want to know after treatment findings?
No, I just want to know whether you get an opportunity to again recheck those samples where treatment has been followed. For example, the very first case in which a child was diagnosed with anemia, there were poikilocytes or microcytes being done. And after the therapy, does the clinician refer back the case to you and see what is the blood picture again?
So if the clinician sends back the sample again, we will have an opportunity to see that on this mirror, doctor.
Okay, but it's not a routine practice, is it?
It depends on hospital to hospital or lab to lab. So based on
Okay.
that, we
Just
get
to
an
know
outcome.
the response, maybe with leukemia or cases, they might be sending
They
it.
could send.
Yeah.
Yes, doctor.
Diagnostic.
Yeah.
Actually, there was a case of acute leukemia which was
Yeah.
diagnosed in Vikram Hospital, and we had scanned serially, like every day consecutively for almost 10 days post treatment
Okay.
after the diagnosis, and we could see the blast count decreasing as well. Not in the particular case as you are asking in the microcytic hypochromic anemia, but
Sure.
yeah, we did do that in a case of acute leukemia which was diagnosed at Manipal Hospital.
Thank you. Thank you.
So if there are no more questions, I would like to conclude this session by thanking Dr. Veena ma'am for gracing this occasion and enlightening us on this beautiful topic. She has very beautifully, elaborated on the pros and cons of using digital pathology platform. Thank you so much, ma'am, for making time out for us, and we would love to see you in our upcoming webinars as well. Thank you so much. And a big thank you to all the participants for attending this session. I'm sure you would have gained a lot out of it. And we also want you to participate in our upcoming webinars as well, and try to incorporate digital pathology in your practice. I would like to lastly thank my medical team, also SigTuple, for organizing this webinars. My medical team is comprised of Dr. Renu ma'am, who is heading the medical department, and then Dr. Chaitra, who has driven this webinar, and she has presented some beautiful cases. And my other colleagues, Dr. Sharita and Dr. Richa, for all their support. And lastly, the IT support from Dhaka. Thank you. Thanks a lot. And I would like to wish all of you good evening and a very happy weekend. And bye till the next webinar, till our next webinar. Thank you so much.